Good, excellent. So good afternoon, everybody. On behalf of the Office for Medical Education at Harvard Medical School, I would like to welcome you to our webinar today. My name is Sarah Fazio, and I'm the Director of Primary Care Education for HMS, an advisory dean at the medical school, and an internist at the Beth Israel Deaconess Medical Center. Today's session is focused on leadership and innovation in primary care, designed to support our HMS students who are part of our primary care tract at Harvard Medical School. Today, we will explore policy pathways for primary care leaders beyond the exam room. I am so excited to introduce our panelists for today. I will give some brief introductions. They have incredible CVs, but hopefully I'll do them justice. So first, I would like to start with Dr. Sam Zager. Representative Sam Zager is serving his third term in the Maine House of Representatives. His legislative work focuses on access to equitable, high quality, low cost, and sustainable healthcare, including primary care, promoting vaccination, housing equity, gun safety, addressing climate change, reducing opiate overdose mortality, and improving social determinants of health, including economic and community development. After 11 years in the Navy, mostly as an intelligence officer, Representative Zager earned his medical degree from Harvard Medical School, where he was a student when I was in a different society. And it's so good to see him again. He completed a family medicine residency at the Maine Medical Center and currently practices as a family physician at Martins Point Healthcare and lives in Portland, Maine. So welcome, Sam.
Thank you so much. Great being here.
Next is Dr. Zuri Song, who is an associate professor of healthcare policy and medicine at Harvard Medical School and a general internist at the Mass General Hospital, where he practices primary care and attends on the inpatient medicine teaching service. Dr. Song's research focuses on health and economic effects of public policies and private sector interventions in the healthcare system. This includes studies of payment reform, Medicare financing, healthcare prices, employer programs, and private capital investments in healthcare delivery. He directs the health policy concentration, the MGH residency program, and leads health policy courses for Harvard medical students, including Essentials that many of you are enrolled in right now. Dr. Song has worked on Medicare payment policy at the U.S. Department of Health and Human Services and with state policymakers on issues around access and affordability. He did his undergrad training at Hopkins, received his MD and PhD in health policy economics from Harvard, and then trained in internal medicine at the MGH. Welcome, Zuri.
Thank you. Thank you, Sarah, for having me.
And last but not least, Dr. Lisa Letourneau is an experienced physician leader and passionate advocate for healthcare system delivery change, with particular interests in advancing primary care, behavioral health integration, rural health, value-based payment, and efforts to address the opiate epidemic. She currently serves as senior advisor to the Maine DHHS Commissioner, advising on healthcare delivery system change efforts. She leads the DHHS rural health transformation efforts, as well as providing support to MaineCare value-based payment efforts, the governor's AI task force, and clinical aspects of Maine's opiate response. During the COVID response for the state of Maine, she helped to support several aspects of the pandemic response, including provider education and outreach related to testing, vaccination, and therapeutic efforts. Prior to joining the DHHS team, Dr. Letourneau served as executive director for Maine Quality Counts and previously served for 8 years as senior director of clinical integration for Maine Health. She received her undergraduate degree from Brown, which is my alma mater, her MD from the Brown Dartmouth Joint Program in Medicine, and her MPH from the Chan School of Public Health. Welcome, Lisa.
Thank you.
Thank you all for being here. Incredibly powerful panel today, and we're so excited to have all of you. And I know that our students are excited. I've got a number of questions for you, and I'm just going to ask each of you in turn to address them. So I will start with our first question, which is what first drew you as a clinician beyond individual patient care into the realm of policy? And maybe we can start with Sam.
Sure. Well, I also want to just shout out to my HMS classmate Zuri, who always seemed to know the right answers. From when we were in lectures, and Lisa, Dr. Letourneau, and I have had great opportunity. I've been a student of hers in essence because she's been doing policy here, health policy, and primary care work here in Maine for much longer than I. Um, I think I first had the inclination to kind of go beyond the clinic when I was a med student at HMS. Actually, I lived in JP, and I remember walking down Center Street one day um, behind some students that were. It was like right in front of the Curley School, the Mary Curley School, and I was thinking they were like 30, 40 feet ahead of me, and I was thinking about something that had just come up. This was back in 2010 or so, and the ripple effects of the financial crisis were kind of hitting the budgets of municipalities, including Boston. And so there was a proposal to shut down some public library branches, which at the surface of it makes some fiscal sense, but when you dig a little bit deeper, you realize that the proposal was to shut them down in some of the most the poorest and least educated census tracts, basically, the neighborhoods that really did not need to have their public library closed. So I was behind these students, and I thought, like, gosh, they have no idea what's going on around them. They're just innocently, going about their day, and the two nearest branch libraries to them could be shut down. So I felt like that was I was reflecting on the social determinants of health stuff that we were learning, in our first and second year work, and knew about education and just community development, in a certain sense. And I showed up at like the church basement grassroots organizing meeting. And there was, of course, all of us were on board with the social justice argument. And I thought, gosh, what about another angle on this? Is there a public health argument to be made, or a health argument to be made that closing libraries is bad for health? So I essentially dug into the literature, and just essentially used some of the tools that we all routinely do when in college or universities or medical school or public health school. And I looked into it, and indeed there were a couple of mechanisms. Certainly, access, reading itself, the raising readers literature that the American Academy of Pediatrics have championed for decades was well established. But then there's this other mechanism of social cohesion, building. So the libraries are more than just the collection of resources they have. They're not just simply books. They are now there's of course more than books, but they are nodes. What is now called social infrastructure. And this is in the 15 or so years since I remember I was walking down Center Street that day. That literature has been evolved a lot more. So I guess that was the start of it. There's kind of more to that story, but I really don't want to hear from the others. But like that was just like a very crystallized moment in my mind about like realizing that even though they weren't my patients, these kids had had a lot to be gained if clinicians were willing to basically to weigh in. Ended up writing up that research as a point paper, a one-page point paper, and shopping it around to people who actually had big credentials. I did not. But when a National Medal of Science recipient or a Nobel laureate or a dean of a medical school or a public health school, and a couple dozen of them sign on to something saying that closing public libraries can be really bad for health, and here's the research why, that ended up helping then the city council in Boston realize that it was a perilous move they were considering, and they ended up finding $1 million, saving the libraries and changing the governance of the library board. So it was a really good sort of evidence-based moment.
Congratulations, Sam. That's a fantastic story. Thank you for sharing. Lisa, do you want to go next?
Sure. I would say my career has sort of been a mix of um, clinical quality improvement, public health, and policy. And so I sort of trace it back to one of my clinical days. And I did emergency medicine for my clinical life for about 8 years. And I remember distinctly taking care of somebody, I don't know, middle-aged, probably much younger than I am now at the time, but a gentleman coming in by rescue who was gray, ashen, elephant sitting on my chest, right? Classic acute MI presentation. And I said to him as he was coming in on the rescue on the stretcher, so, Mr. So-and-so, do you have a history of heart disease? And he said, no, no, I don't know what's going on. And so we quickly undressed him, put him in a Johnny, and I see this zipper scar running down the front of his sternum. And I was like, oh, Mr. So-and-so, you kind of looks like you've had a heart surgery, bypass surgery maybe. And he says, oh, yeah. Oh yeah, my doctor did that, but they fixed it and I'm fine now. I thought, oh dear goodness. And he and not infrequently many others I would see in the emergency department with what felt like similar issues, similar background issues. And I just thought, gosh, what am I doing here? One patient at a time. And it seems like there's much bigger issues upstream that need attention and work. And that was sort of the start of looking for other bigger approaches. And I've kind of had an interesting path, I think, in my career, going from one-on-one care in the ED to working for a health system. I actually worked briefly for a health plan, to having a statewide nonprofit, and now working at the state government level, which I always said I wouldn't do, curiously enough. And here I am, 7 years, 8 years because I'm too impatient. And it's increasingly, I would say, for students thinking about this, less and less control over my immediate environment, as though we ever have control, but more ability for more opportunity for impact, I think, at a wider level. So it's just been an interesting journey.
That's a fantastic story. Thank you for sharing it, Lisa. Zuri.
Great to be here with Sam and Lisa. Nice to meet you, Lisa. And also shout out to you, Sam, for your incredible work, to you both. And for all the first years whom I saw this morning in class, thank you guys for being here. So from the research perspective, the motivation for studying healthcare policy and either the economics or other structural or forces behind healthcare policy is to produce evidence that policymakers can use to inform their decision making. Fundamentally, at the end of the day, there's a scientific motivation for policy making, sometimes called evidence-based policy, like Sam demonstrated. And it is incumbent upon the research community, those of us, various social sciences and clinical research communities, to try to generate evidence that is useful for policy making. And that is what motivated me in part to go to graduate school, to study health policy and economics. It's still what motivates me today in a lot of the work that my colleagues and I do on healthcare policy topics, whether it's primary care or otherwise. And from doing research in health policy, there usually comes a moment where one becomes either curious or inspired by the role that a piece of evidence or a body of evidence plays in a certain policy area, and starts to consider opportunities to get involved more directly in policy making. And I had my own version of that journey of experiences. And so had a real privilege in working with colleagues in the federal government and in several state governments, state legislatures, including Massachusetts, on issues around protecting patients and frontline doctors from private equity involvement in healthcare delivery, to investing in primary care, to other issues around access and affordability. So from the researcher's perspective, there are opportunities to work directly in policy while trying to produce the evidence as one goes along.
Thanks so much, sir. My next question, two of you actually have addressed this already, but I'll just throw it out there to put it front and center. If you can, and Sam, you actually did this, share a turning point where you realize advocacy was essential to your work within primary care, and any one of you, perhaps, but when did that become? I think Sam, you articulated really well that it was part of the process for you up front. Zuri or Lisa? No, go ahead, Sam.
Well, I was just going to add that I didn't like stay in policy. Like that was like on a one-off thing as far as I was concerned. And then in 2017, a new administration came into office in Washington, and a Congress, a sympathetic Congress, wanted to undo the Affordable Care Act. And thinking back to my elementary school days, I knew that if they were going to do that, they had to get through the U.S. Senate. And I, at the time it was a 53 to 47 split. And one of those, the potential votes was Susan Collins, Senator Collins, of Maine. And Maine is a relatively unpopulous state, 1.4 million people or so. And it's not hard to get a movement going, especially when there's an audience of one. And so it just seemed like a really outsized opportunity for a group of, in that case, it was a few hundred healthcare providers, doctors, nurses, social workers, et cetera, who said essentially we have to organize, we have to, there's like 20 million people's healthcare at stake, and many other things, provisions in the bill, and we have to impress upon our this elected leader who happens to be among a handful of people who can really influence what's going on in this country. And so we essentially did that. We had a whole, that was another grassroots thing that was a whole effort that lasted about a half year, from roughly January living room meeting to June was the first meeting, first vote in the Senate. And then there were two more votes later that summer, and in all three of them, Senator Collins and Senator Murkowski and Senator John McCain of Arizona held together. The Affordable Care Act remained in effect. That story is, of course, not over, but for all those years since then, there have been a lot of people who have had health insurance and all the other provisions. So that was another sort of example or moment where I realized that I think I was wrestling with the, like, is this a fair use of one's time to go through medical school and residency and all that other stuff and have the privilege of have people entrust their privacy to you to practice medicine, or to step away from that for some of your time and to do something that may not lead anywhere. Policy work does not always yield what you want it to. There's the sort of cost of doing business in terms of time and energy. And so I had to wrestle with the ethics of that. But when I thought about things like, the experience with the 2017, the Affordable Care Act, Senator Collins, and the advocacy that Maine Providers Standing Up for Healthcare did, that convinced me that advocacy can indeed be part of the expression of the Hippocratic Oath, and the motto of HMS is to reduce suffering caused by human disease. There's so much in the policy realm that is very much in line with that mission.
Thanks, Sam. That's an incredible example. My next question is, for those of you still practicing, how do you balance clinical identity with your role as a policy advocate or a leader? And does one inform the other?
So I also love to hear from Lisa. I would just blending the two questions together. Interestingly, from a research or science perspective, advocacy is a really interesting thing to think about, because there's often an ethos that when you do scientific investigation and research, there's a certain responsibility to come at that from an objective viewpoint, where you are decidedly not an advocate, but rather following the data and let the data take you where it's going to take you. Of course, we're all human beings, even researchers, and upon being taken to where the data are going to take you, you can formulate your own opinions and normative views about the findings and about the implications of data for policy. And as I told the first year class on Tuesday morning, everybody has their own valid and normative views, which should be respected. And discussed and debated. But the generation of the evidence is in some sense in a protected space of we're going to set aside our personal normative views and do the best science that we can. So, I was trained in graduate school in that social science research perspective, which is, again, by design, not advocacy. But now that I've engaged in more policy work with colleagues at the state and federal levels, there are many opportunities where your evidence-informed view of the world can inform policy decision-making, where on the one hand, it's advocacy. On the other hand, it's really evidence translation. It's taking a set of studies or a body of literature and synthesizing it for a policymaker or a staffer, or presenting to a legislator how you think the evidence translates to this real event on the ground that they're grappling with. So, for example, when Steward Healthcare in Massachusetts went into bankruptcy as partly a result of a private equity acquisition, and the state had to respond last year, taking that body of evidence and helping to translate it through public hearings and then private meetings with legislators was, in my view, part of the responsibility of being a social scientist or a researcher. And I can convey that from a classroom standpoint where it's presenting them the data without attaching my own views to it. And then afterwards share what I think it means for their decisions at hand, where you could then take on a more advocacy kind of lens. So academia or research allows you to do both. But I do think there is a separation between the two. That's important to keep in mind. And I think in what I just said, there is kind of that example of that experience at our state level, which was definitely formative for me and very meaningful. So I'll pass it on to Lisa.
Sure. So just a couple of things. Certainly would agree with everything that's been said and impressed by the range of experience. You guys have some real experts here with Dr. Song and Dr. Zager. That's amazing. You've got quite a panel here. I actually, I remember when I was at the Harvard School of Public Health, I just remember sitting there thinking, oh my gosh, I like a kid in a candy store. Like, these people are amazing. So I hope you're appreciating these incredible colleagues here today. But I think, to build on what Siri said, that you really will hold a unique role in your community and be seen as experts, as physicians, and the ability to inform policy with your knowledge and experience. I mean, if you think about policymakers, legislators, state staff, they have an incredible job. They're supposed to know like everything about everything, right? The range of issues. So I think that they often very much welcome the expertise of trained professionals. And as a physician, again, I think you hold a unique or will hold a unique position there. And I think forming relationships with state legislators or policymakers really allows you to have that opportunity to perhaps inform and influence policy as it's being made. In terms of the question, you balance your clinical identity with your role. I've had to very much take that head on, not so much my clinical role, but sort of my personal role as somebody who works for the state. I have to be very clear about which hat and which head I'm speaking from. And as an employee of the state, you really, and I work for the executive branch, so I really can't advocate in that role. And yet my First Amendment rights let me speak on issues that are important to me. So I will not infrequently testify at legislative hearings as Lisa Letourneau, private citizen, but I need to talk with my boss first about that, and identify myself in that role. So I think there are different ways to very concretely kind of split out those identities.
Thanks, Lisa. That's incredibly helpful. Sam or Zuri, any thoughts on the clinical aspect and how that has continued to inform your policy interactions and how that's been for you?
I think one of the things that I mean, being in a legislature is kind of like, I think, being an artist or a musician. Like, there's so many different ways of doing it. There's basic principles and the basic rules that, are things that structure to the experience, but there's so many different ways of doing it. One of the features of the ways that I do it is to be very evidence-based as much as possible, which is very difficult. It's kind of like being if you can like have a time machine and would go back to a time when you were a physician, but it was before all the evidence was amassed. or like you would want to, you would hunger for information, like what does this intervention yield what I want it to yield for this patient? And there's no research. That is a lot of times what it's like to be in the in legislative discussions. There's also the tremendous challenge of just the sheer volume. Like as a researcher, and I've done a ton, Dr. Song is like a leader in research. He really knows. He's every other day I see a JAMA publication or a New England Journal publication that with his name on it. I've done a little bit of that, and I a little bit of research. I've had, one of the things that I've learned from that is that you sort of have the luxury to really focus. Like you can spend a long time looking at basically one question. In a legislature, you have like 3,000 questions, and you have to hit yes or no on all of those, basically. And so you don't have this goes back to what was said earlier, is that there's a lot of legislators who realize that they're out of their expertise, and they would love a trusted consultant to help guide them. And that's where, evidence-based research really can play a role. There's also relationship building, which we don't always talk about when we think of the the scientific method, and that is also part of it. And advocacy is not only what you say, but who is saying it and how trusted that voice is. And that is a whole area, whole other thing that we could talk about today or another day, but that's really important too. So those are some of the things that I try to bring to my advocacy work is as evidence basis. Sometimes that means standing up to my friends who want to advocate for something or say something should be done a certain way when there's really no evidence for that, or the evidence actually contradicts that. And I've had to sometimes quietly say, I want to agree with you. Is there how do we know that that's true? And that is part of, I think that's part of it, gaining credibility, because people know that if you are advocating for something, that you've generally had a process for that, and that you can be trusted, that you've done your due diligence. But that other thing is the relationship, being somebody that is trustworthy, that is hardworking, that has the right principles in mind, the right people in like that you're doing it for the right reasons, and that also all plays a role in how one can be an advocate to improve, to improve health, reduce suffering caused by human disease.
Thanks, Sam.
I think I'm always struck at how much society affords us, or how much credit society gives us simply because we are physicians. And indeed, even as medical students, you are given a platform and a voice by virtue of your clinical training that gets you respect and an audience, even if we feel like we don't deserve that audience yet. Because you're a healthcare provider, people will listen to you. So your voice is really important. If you feel strongly about policy issues, and we'll talk about some of this later this month in our course for the first years, you absolutely can make a big difference in any policy area that you want to dive into or you feel strongly about. It might take a little bit of background research to get up to speed on the evidence, like Sam said. It might take some social networking to get yourself in front of people with influence and the opportunity to shape policy. But the road between here and there is not that long. And when you get there, you can make a huge difference. At the end of the day, there are just not that many doctors in health policy. Mm-hmm. It's just a flat out persistent fact. The vast majority of physicians do not participate in health policy at all, despite how much policy shapes their lives and their patients' lives. So if you choose to, you have lots of opportunities to make a big difference. And you should feel the confidence and the autonomy to be able to do that, even during medical school.
Thanks, sir. Springing from that last statement, which is really unsettling, actually, just given how much of an impact it has on all of us and our patients that we don't have more physicians involved. What barriers would you all say keep primary care clinicians from engaging in policy work, and how can we overcome them?
I think one, oh, go ahead, Lisa.
Go ahead. It's fine. You're the practicing doc.
So are you. Love to hear what you have to say.
Go ahead, Lisa.
Well, I suspect we're all going to say the same thing, which is time, and time, right? That given, despite the work of all of us for the past many years, primary care is still far too heavily pressured to produce volume and revenue and RVUs. And so there's just this productivity focus that's far more prevalent than I wish we still had. And that is often the biggest thing. Plus, the reality that most primary care providers right now in this country work for somebody. We're not still in the day of practices, providers running their own practices. So whether it's a hospital, a health system, a larger practice, it is a challenge. And I think, one of the solutions is to get those, number one, know where you're practicing and practice someplace where they think advocacy is important, and have those discussions up front as you're negotiating a position, if this is something that you want to be part of your role. I think Sam's organization clearly values his role as a policy leader in the state, and have accommodated that, I suspect, in countless ways, because they see the value of it. That's not the same for every practice. So I think it's a challenge, but it's not something you can't overcome with forethought and passion. And I'm sure Sam has made very articulate arguments for why it's good for the organization as well. And I suspect Zeri is part of your role as well. I just know it less well for you.
Sam.
Yeah, that's well said. And just to add to that, I mean, certainly time. There's also a financial cost that some physicians, for better or for worse, choose not to, they don't want to forego whatever financial benefit from continuing to practice during that time. I mentioned the moral quandary that one might face or pose to themselves about whether it's an appropriate use of one's training. As I said before, I think it very much is, and I think we can make a very strong case for it. And the last thing I would add is a sort of a self-imposed bias, where, especially among PCPs, when I'm at conferences, and some PCPs will be saying like that well, they're not an expert. It's like, okay, like, yes, if the bill is about colon cancer screening, or funding for a colon cancer screening, you're not a gastroenterologist. True, but you don't have to be a gastroenterologist to talk to be able to make a compelling case for how, what the number need to screen how that matters to people at the human level. And also, as one can make like a health systems benefit argument as well. So I think that is a problem for that doctors, especially PCPs, family docs, internists, et cetera, have to get beyond. That you don't have to have a PhD in something to be able to testify about it. What you do need to do is have a grounding. When I say basic, I mean, you're already there. If you're a first or second year medical school student, you already have the grounding, the basis to speak about a very wide variety of topics. You might need to practice, you might need to do a little reading, but you know how to do a little reading. And might maybe do a little writing, you know how to do that as well. So I think that's really important. It's kind of like, we keep ourselves out of the picture. And that is to the detriment of not only our patients, but the people who might otherwise be our patients if they could have health insurance, or could get to the clinic that despite the transportation or the rurality or the socioeconomic barriers or the other things, that if you want to be there for them, maybe we have to reconsider how comfortable we really feel like we need to be before we're willing to step into a conversation. And that conversation, that could be in real time, that could be showing up at a hearing, but it could also be writing an op-ed, which is very, very, very valuable, and getting involved in other ways too. It's really, I think that the key thing is to realize that on this call, like if you're a medical student, you have the expertise, you have also the wherewithal and the privilege to like dig into the literature, to talk, in social networks, talk to folks in HMS, like who knows a little bit more about this. I'd love to be able to write a little piece for the Boston Globe. You know how to do this, and I think one can. It doesn't mean that one has to. Advocacy is one facet that one could fold into your clinical life or your life as a doctor. But it doesn't have to be done, but it can be done, and it can be done intermittently, ad hoc. It can be done as part of your career, like a consistent part of your career. But it's definitely something well within reach of every single person on this in this session.
Thanks, Sam. I love that call to action. It's fantastic. Zuri, thoughts?
I agree with Lisa and Sam.
Fantastic. The next question we've spoken about a little bit, but thinking on a more sort of bit by bit level in terms of things that can be done for our trainees and early career clinicians, what are other small but meaningful ways to get involved in advocacy today? I love the idea of an op-ed, or writing a position paper. And I know, Sam, you've thought a lot about this.
Is that a cue?
That's a cue, yes. Would you
It
like to
is something.
share?
It is something that I've thought a lot about. I mean, I think the first thing is voting. There is. I'm gonna show a little, actually so unfortunately, physicians don't vote in a very high rate. That is the easiest, simple, most straightforward way that one can do a little bit and be an advocate. I mean, there was. Share this. Can people see the physician voting rate slide?
Yes.
Okay. So is it large enough? Is it filling the screen?
It's not filling the screen.
Okay. Let me here we go. Okay. How's that?
Same, although we can see it. We just see all of your slides. It's not in sort of slide presentation mode.
Forgive me. I must have hit something wrong.
But we can see it.
Okay. Well, the basic idea here is that
Perfect.
So this was published in JAMA a few years ago, and it's showing that physicians in the for elections from roughly 2000 through 2020, physicians voting for the most part less than the general population, and both physicians and the general population voting roughly 2/3 of the time. This varies a little bit depending on whether it's a off-year election or a presidential year election and so forth. But my point is that I think this, some of us are going to be on call and we don't live in states where there's absentee voting or mail-in voting or something. But I think this number could be closer to 90% or higher for physicians voting. So I think the first thing is voting. There's another thing that people can do is get involved in an organization. It can be the Massachusetts Medical Association. It can be a advocacy organization. Trying to do unshare, but It can be an advocacy organization dealing with climate change or gun safety or reproductive rights. All the websites have a get involved or advocacy section, and just say you're a med student, you're a doctor, and you want to get involved. You have 2 hours a week or whatever it is. You're on a block, and you have you have a little bit more flexibility, and you have a week where you can do like whatever it is. Just say that you can do it. And that again, it's not something one has to do. There's a lot of ways that one a lot of facets of being a physician, being a medical student. But whether it's voting, whether it's joining or getting involved with an advocacy organization, whether it's writing an op-ed, whether it's showing up to testify, there's really a lot of ways to do it, and it can be done on your terms, in a way that suits your personal life, your own mental health, your patient's needs. All these things can be balanced. If but I think we should open the door for more physicians to advocate for their patients.
Such an excellent point, and something that not just trainees but faculty at all levels, I think, could take to heart. Thank
Yeah,
you.
so just to add on real quick, at Mass General Brigham, we actually have a colleague who is a writer in residence, and part of her job is to help residents and physicians on staff develop their narrative and their voices through writing. And she has counseled and mentored many of my colleagues to write op-eds for major newspapers, Washington Post, Boston Globe, New York Times. They've been really successful, as well as perspectives and viewpoints for the New England Journal and JAMA types of journals. So you can certainly get your voice out that way. In our era these days, you can also just start your own podcast. I mean, this is not something that any of us probably would have said 10 years ago, but there are medical students across the country who have really successful podcasts. And if you have an audience and a following, you can shape hearts and minds that way. But for like direct policy impact, I think the writing helps to the extent you can get it to the right audiences, and then the direct communication with staffers and legislators is really important. The most underappreciated resource, in my opinion, in the policy infrastructure at both the federal and state levels is staffers. They are not given the credit that they often deserve. They work under the elected person, but especially at the federal level, many staffers are tasked with big health policy issues in their portfolio where they have to study late into the night, develop recommendations, help with the bills, run the hearings. They have to become subject matter experts really quickly. Many of them are not far from college graduation. They're in their 20s, maybe early 30s, on the Hill for 3, 5, 7 years and having to do like really important work. And many staffers benefit from direct communication with academics, with researchers, with subject matter experts, of which they become one very quickly. So if you can develop relationships with staffers, even though that's quote unquote behind the scenes, it's incredibly effective. Many legislators depend on their staffers to do what they do every day.
Agree 100%. Staffers, people often ask me, is it like, have I been discounted if they say talk to my staffer, or talk, want to talk to? Not at all. Like it is really, really valuable to get some time with somebody who has that portfolio for a particular elected leader, for sure.
That's incredibly helpful to hear. My next question, I've got two more, and then we're going to open it up for some Q&A, since I'm certain that the students and audience have questions for you guys. How, and this is for any one of you, how do you sustain hope, motivation, whatnot, when policy change can feel slow and incremental, and also in our current environment when evidence and science is devalued as much as it is lately? How do you maintain your passion and drive going forward? Lisa?
Oh boy, I got the easy ones.
Yeah, no, sorry.
In many ways, I think one chooses hope. I choose hope because I don't tolerate the alternative, right? So it is a very dark time right now. There's no denying that, and particularly, the last days and weeks. And I actively choose hope. I think, as I mentioned early on, I'm not never thought I'd work for state government because it is slow and bureaucratic, and yet the opportunities for impact are very significant. And so feeling like now more than ever, it is a critical time to be working on the side of what you think is right and necessary. And if we don't, what's the alternative? So choice.
I love that. Zuri?
Yeah, I think the pursuit of truth or scientific truth, in the purview of the researcher, is completely agnostic to the political winds of the day. So the demand of doing rigorous, good science to get an answer to an important policy or scientific question, that need is the same no matter who's in office or what the political realities are. So I think from a researcher's perspective, it's easier, relatively speaking, to kind of pursue, the Veritas kind of shield ethos. I think can keep the research going as long as you have funding, I suppose. But from the translational perspective, I totally agree with what Lisa said. Once the evidence is out there, how it's used is definitely susceptible and largely driven by people's normative views of the world and political preferences. So then your participation in the use of the evidence involves a lot of choices. So choosing to be hopeful, like Lisa said, totally resonates with me and I think many others. But yeah, I think there are many ways to sort of play a positive role, be a positive force in this. So is teaching and mentoring, or just simply, and this is not simple, but be the best doctor that you can be. To be the best person for the patient in front of you is already, that's a win. That matters. So,
Sam, your thought?
No, I underline what's already been said. I'm also I majored in history. I remain a very avid student of history, and it's not an uplifting story. When you read about what people have done to each other and to the planet, but many leaders as many leaders have pointed out, perhaps most famously recently, President Obama, is that the arc of justice, the arc of history bends towards justice, and I think that's not necessarily preordained. I think that's because the human spirit and other things that circumstances, but that we are seeking something, and maybe it's evolutionary, maybe it's just something in us, but like we are seeking a way to live together, and we are seeking our own fulfillments. We are seeking, safety and health and wellness and prosperity for our loved ones. These patterns are, seen throughout history, and certainly bad, awful injustices have occurred, still are occurring, and so we're not alone in being horrified, or perhaps feeling like it, how could it get any worse? But I'm encouraged when I look back a little bit and see that things have been a lot worse, and today are also worse than certainly I have it. So I feel like it's I can wake up the next day and try a little harder, even when I'm incredibly discouraged by what happened the previous day.
Very inspirational answer from all of you. I really appreciate that. I want to capitalize on this side discussion that's happening. I see in the chat, and just highlight maybe the question to each of you, perhaps starting with Zuri, since I know you've kindly answered a few questions. What do you think, and I'll ask each of you this, the most pressing policy issues are currently facing primary care?
I think the underfinancing is probably the top one, but it's very much connected to the not exactly dry or parched, but fairly slow pipeline or insufficient pipeline of new trainees going into primary care. Less than 30% of primary care residents today who have self-declared and matched into primary care residencies actually stay in primary care by the end of their third year of residency. So for some reason, and I think we can all point to probably why, primary care careers have not been as appealing to residents and medical students as they probably could be. And that traces back to actually what we'll talk about in class next week, which is how things are priced in the physician fee schedule and why primary care has been underfinanced historically and what can be done about that. But the underfinancing piece has been with us since the late 80s. And we've tried, the federal and state governments have really tried, as many health systems have too, to some degree, to do something about that, to put more resources into primary care, to make it more appealing as a job, more enjoyable as a lifestyle, as a career, with varied degrees of success. But at the end of the day, the underfinancing relative to other specialties persists. So I would still nominate that as the top issue.
I think that's fair. Lisa?
Certainly would agree with that. And I just couple that with the way primary care is paid, right? And certainly Sarah is one of the experts on that, but the fee-for-service system really has not, we've not been able to budge that considerably towards what I think we would all agree needs to be a more population-based payment or capitation for primary care, to use an older word. But we've got to change it from the fee-for-service system. And I think some would argue, including some of your colleagues in Massachusetts, that there could be value in just taking it out of the current insurance system and paying for it entirely differently. So the how much and how it's paid is just not helping.
Indeed. Sam, thoughts?
Nothing really to add at this moment.
Thank you. Just looking to see if there are other specific questions that haven't been answered in our chat. Let's just have each of you, since we've got about 5 minutes left, tell us something that you all are so inspirational in what you've done and been able to accomplish, but perhaps leave us with a message about sort of healthcare policy and primary care that leaves us recognizing that we actually can play an important role, and that students who are coming into the profession can make a profound impact. So I guess final thoughts that can leave us with something to look forward to.
I was just going to flag there is a question or two in the Q&A as well, but your call.
Let me just pull it up. Why don't you just leave us with some thoughts? I think there are some really specific ones there. I'm kind of going through them since we only have a couple of minutes.
Well, I'll jump in, and on that last one, are there incentives to get people into primary care? I think that's a great question, and I think absolutely there are. We could absolutely dedicate financial incentives. We could pay for primary care. We could use state or federal funds specifically to incent students to go into primary care. One of the difficulties is then how do you what are the mechanisms for holding people to that? And if we end up with a workplace that is still very unattractive because of the payment issues that we talked about, then, how do we make it an attractive place? So I think it's just many things at once. Sam and I are recently starting work on a Maine Primary Care Advisory Council that is modeled after efforts in similar states, including Massachusetts, just starting. So I look forward to thinking about how do we get at these issues through multiple channels, because it's not just one.
Fantastic. Thanks, Lisa.
Yeah, I think there are huge opportunities for all of you, all of our students here in primary care. I know that historically, if you talk to perhaps our parents' generation or even our peers today, or when you go on the wards for our year, there's this sort of hidden curriculum or this socialization of, if you're smart and capable, you should go into one of the many amazing specialties, and that somehow primary care is seen as like a less attractive choice. And historically, that may have been pervasive through medical school training and even residencies. But I mean, times are changing in many ways. The financing of healthcare in general is shifting towards the need to slow total healthcare spending. And believe it or not, primary care is the only area in the active policy discussion where efforts are trying to increase the spending for it. Primary care is only 4 to 5% of US healthcare spending. And many states, along with the federal government, is trying to spend more on primary care, while all the other policy efforts around healthcare spending is about slowing and constraining and reducing and capping the rest of spending. So hospital spending is growing unsustainably. Specialty spending has been growing unsustainably. And all these policy efforts are about how to make that big part of the pie a little smaller or just grow a little slower. But primary care is the area where everybody's trying to grow it faster. And yet, we still have this persistent sense that going into primary care as a career is somehow like second class. And I just want our students, I'm not pressuring or trying to persuade anybody, but to just note that we ought to probably think of that a little differently. In the next 5, 10, 15, 20 years, there will be opportunities to lead in primary care and to change and shape it that just didn't exist before, probably with resources that did not exist before. And just at a moment in our nation's history where our population is aging and people increasingly need high quality primary care to manage multiple comorbidities. So I don't think we should buy into some of those older narratives about primary care, even if we still hear it.
Love that. Sam, any last words?
I mean, there's so much, has been beautifully said. I mean, I love being a primary care doctor. I love doing advocacy work. I think they work beautifully together. And in fact, in some ways, being a PCP is actually has the more credibility in policy work. I've done advocacy a little bit in Massachusetts when I was a med student, and a lot in Maine, and also in DC. And because, I mean, our credential, it's not just an academic credential or the residency graduation credential, or it's also that we sit and listen to people. We're there. We take their suffering or their fears or their questions or their hopes, and we put that into a context and talk to other decision makers who can make things better for the next day or for the next generation. And that credential of being a listener, building relationships, and so that people will divulge these sort of things, that is a very powerful credential. And that is something that elected leaders and other influential people can sense. And that's primary care every day of the week. It's that listening, it's that relationship building, it's that understanding people's health in the context of their lives. And so I think primary care that's part of what I love about primary care. And it's part of what I think is compelling about primary care with regard to health and other policy questions.
Thanks,
Really
Sam.
well said, Sam. Thank you.
It's beautifully well said. And I just want to, as we are already 2 minutes past the hour, just say what an inspirational talk this has been and what an incredible panel the three of you have been for us. And we just thank you so much for your time. Our next session will be exploring shaping the future of addiction care, primary care leaders as advocates and innovators. And we'll be reaching out soon with some details. So thank you again to our panelists and to all of the trainees and faculty who joined the webinar today. Thanks so much.
Thank you all. Great to be here.
Thank
Thank you,
you.
Sarah.
Good luck. Bye-bye.
Take care.
Bye-bye.